Hey, GLP-1 plus size community. Before we jump into the podcast, please take the time to leave us a 5-star review on whatever audio platform you're listening to the podcast on. Share your story and how the podcast has helped you. This will help us get referred up in the audio platform so that we can reach more people that need our help. Our support and guidance from our doctors. Help us get loud and change things. Hey, Dr. Young.
Hi,
Thanks for
Dr.
being
Young.
here.
I've got to say something because this is my big reveal, because I've been trying to stay incognito on TikTok and not tell anybody my real name or where I am. So this is the first time I'm going public.
Oh, yay! And for a lovely cause.
Thank you.
Hashtag remove the stigma. It's an excellent cause.
Yes.
Well, we're super glad to have you here.
Oh,
For
thank you for
those people
inviting me.
who are not on TikTok and do not follow you and do not know about you because you're all incognito, can you tell us a little bit about you, like your, what you do for a living, for example?
As you said, I'm an endocrinologist. I'm in solo private practice, and I'm a TikTok creator. And it initially started with just short educational things about general endocrinology, and then because of a lot of the insurance restrictions, I want to say maybe half of my videos now are also about, as one commenter called it, healthcare slander. So prior authorizations and insurance.
Healthcare slander.
Healthcare slander. Okay.
So for those of us that are not type 2 yet, and hopefully ever, many of us, I would say we would like to understand a little bit about what is the focus of an endocrinologist in terms of your specialty.
Yeah.
So endocrinology in general is the branch of internal medicine that deals with hormones. And a lot of times when people think of hormones, they think only of estrogen and testosterone, but there are dozens and dozens of different hormones in the body. So we treat disorders, pituitary, thyroid, adrenal, calcium disorders, and we do treat, abnormalities in estrogen and testosterone. And sometimes people don't understand why diabetes and obesity are part of endocrinology for studying hormones, but they are very hormone based. Insulin is a hormone, and glucagon is a hormone, and and GLP-1 is a hormone that's made by the GI tract. So the general description is that it's the branch of medicine that deals with hormones. But some endocrinologists will be very specific and only treat certain diseases. Most of us do general endocrinology and do some of everything, but because of the number of people who have diabetes and who have obesity, they make up a large proportion of the patients that we see.
Yeah. Okay.
Yeah.
Awesome.
Can you talk a little bit more about how obesity and type 2 are related and why the same therapies tend, right now at least, are working, successfully for both?
So, there are some people who want to change the name of the disease, obesity, to adiposity-based chronic disease. Because once upon a time, we thought of the fat cells as just being storage for excess calories. But now we understand that these fat cells actually secrete substances in our body that alter the way our body works. And so when people have excess adiposity, when they have diabetes, it keeps our body from using insulin efficiently. And that's what we call insulin resistance. So in order to keep the blood sugars normal, the body needs to make additional insulin. But over time, it's less and less able to do that. So, and that is when people develop type 2 diabetes. So type 2 diabetes is one of the consequences of having excess adiposity, excess fat tissue.
Wow.
And so the medications that work to address weight also help to address type 2 diabetes. In the past, we focused mainly on just lowering blood sugar because that's what we had. We had medications that made you make more insulin, or we had insulin, or we had medications that helped you to use insulin better. This is it's only in the last several years that we've had tools to help us decrease weight in order to address all those other things.
Yeah.
Yeah.
And how is
Fascinating.
that all related to like insulin resistance? And what does that really mean for someone?
So insulin resistance is, that state in which the body isn't using insulin efficiently. So that means that the muscles aren't taking up glucose, that the liver is making extra sugar. And there's other things that insulin does in the body other than regulate sugar. It has an impact on our reproductive hormones. And that's why people who have adiposity, who have obesity, are also at high risk of developing polycystic ovarian syndrome, because they're all part of that insulin resistant spectrum.
Go to their doctor, whether it's an endocrinologist or whether it's their PCP, and they ask to be tested for insulin resistance. And what they get back is an A1C or a glucose test. So why is that so hard to get?
Because, how do I put this? I think that I'm not sure that changes management, right? Because if you're looking at someone who has overweight or obesity, whether or not they currently have insulin resistance, I hate to say it doesn't matter, but it kind of doesn't matter, because you're still going to treat, right, the overweight, and you're still going to treat the obesity, regardless of whether or not the insulin resistance is present now, because the risk of them developing it at some point is there. And so instead of, measuring, and offline earlier, Dave had asked about measuring HOMA-IR, which is a measure of insulin resistance. We generally don't do that on a regular basis. They do it a lot in clinical studies, but we don't do that clinically, because I think the management doesn't really alter by doing those kinds of tests.
As I understand it, one of the common, I don't want to call it a comorbidity because that's not what it is, but something that usually can commonly go hand in hand in insulin resistance with women would be PCOS, right? And on my own channel, I hear from many, many women who are struggling with PCOS, who are on some sort of GLP medicine that has helped ease that for them. I'm curious from the male side of things, are there common, like, as it relates to men's sexual health, are there common issues that go along with high insulin resistance as well, like there is PCOS in women, if that question makes sense?
Yeah, so not the insulin resistance itself, but again, that excess adiposity, the fat cells convert testosterone to estrogen. And so men who have overweight and obesity, and men who have type 2 diabetes, are at higher risk of developing low testosterone. A couple of reasons, partly because of that, and because that extra adiposity also affects the way the pituitary tells the testicles to make more testosterone.
Whoa.
And so weight loss can also be, I don't want to say the cure, but it can be the answer for some men's low testosterone levels.
Wow.
Wow.
Excellent.
Dr. Young, you heard Manuel the Mounjaro share his experience about, trying to reverse his type 2 diabetes, and how difficult it was to lose weight and, enough weight and to keep it off, even eating strict keto. Why is that?
So, the weight loss industry is a multi-million-dollar industry for a reason. I mean, and I think, diet and exercise is great for weight gain prevention. Once someone has gained weight, there are metabolic and neurologic and hormonal changes that occur in our body that prevent us from losing weight and keeping it off. We evolved centuries ago to deal with famine and drought and winter. And the families that survived were the people who could hang on to energy, people who could hang on to fat. We have not re-evolved to deal with grocery stores and restaurants and DoorDash. So when we try to diet, when we try to restrict calories, our body says, no, you're not supposed to be down there. You're supposed to be up here, and tries to bring us back to that prior weight. And that's why people yo-yo. There are hormones that get secreted that say you should be eating, right? And it becomes very difficult to keep that weight off. So Dave is certainly not alone in that, having the weight go back and forth. And the medications, the GLP-1 receptor agonists, help to address some of those hormonal changes that have occurred.
Yeah.
Okay.
Fascinating.
Wow. Thank you. Yeah. So, okay. So I have another question. Um, we've talked about offline the importance of having like a full panel of blood work done, especially prior to beginning a GLP-1. So, how important is it to have blood work done prior to starting a GLP-1? And what should a doctor look for, and what test should be like run before you start a GLP-1?
Well, it depends on the purpose of starting it. I mean, if the main purpose is for diabetes control, for type 2 diabetes, and of course we want a hemoglobin A1C. For safety purposes, I think it's important to get a lipid panel, because although the data is not entirely clear as to whether or not the GLP-1 receptor agonists truly increase the risk of developing pancreatitis, it is in the label. And there are some animal studies that suggest that. And so if someone has very high triglycerides, that is also a risk factor for pancreatitis. So I am usually very cautious about using a GLP-1 receptor agonist in someone who has other risk factors for developing pancreatitis. You also want to make sure that their kidney function is okay, because sometimes people get dehydrated because of the nausea and the diarrhea. Sometimes people get dehydration when they start a GLP-1 receptor agonist. So you want to make sure that their baseline kidney function is okay.
Okay.
"20 seconds a week to lose 20% of your weight in a year with diet and exercise." That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Would you mind me jumping in and asking a question about my own insulin levels?
No, you have to leave now.
Yeah, sorry.
You're
You gotta
fired.
go.
I'm out. Forget it.
Come back.
Yeah, please grovel. Maybe I'll come back. So the very interesting thing to me is I hadn't looked at this in months, but I need to do updated blood work. But the day that I was diagnosed with type 2 diabetes, my insulin level, and this is measured in a measurement called ZZ, and I don't know what to make of that. I've Googled it. I can't. Maybe Melissa can make sense of it, but it was 38.3, and the standard range it gave was 2.6 to 37.6. So I was 38.3, so higher than the high end. After a few months, I had it checked again, and this was after a few months of very strict keto, and it was 34.8. So still really high, even though I shouldn't have theoretically needed near the amount of insulin over that period of time, because I simply wasn't eating carbohydrates. Now, I've come to understand, obviously, that the liver I have fatty liver as well. And so it was in hyper mode of producing extra glucose in the blood, but I would have expected to see a bigger dip. Towards the end, about a month and a half before I went in for my year follow-up, or before, it was about a month and a half before my year follow-up would have been, I went in and got it checked again. And I had been off the wagon for about a month on keto, and that level had jumped up to 48.2.
Whoa.
And so, like, these are super, super high insulin numbers. Ultimately with tirzepatide specifically, it does such a good job bringing the sugars down, and I wear a CGM. Like, after a year, should I expect that to be much lower? I mean, these seem like crazy high insulin numbers to have.
So again, I generally don't follow insulin levels, because I don't think that really adds much to therapy. But part of it depends on what your glucose is at the same time that the insulin level is drawn. Because remember, your body's going to try to make enough insulin to keep your blood sugars normal.
Sure.
And remember, Mounjaro makes you make more insulin.
Right.
right? And the
Right.
GLP-1 receptor agonist. So it's kind of hard to interpret those tests when you're on medication.
That was
Oh,
that was
okay.
one of my
Yeah.
fears, and I actually asked my doctor about this before I went on. I said, so my insulin level is at 48.2, which is significantly higher than the standard range. And now I'm going to go on a medication that's going to encourage my body to make more insulin. And my concern was, could this not over time really tax your pancreas?
Since it only makes you make more insulin when your blood sugars are above the target range, then no. Plus, with the weight loss and your body using insulin more efficiently, eventually over time that should get better. And so, no. And actually, there's some data, not with tirzepatide, but with some of the older GLP-1 receptor agonists. There's actually data that may help to preserve beta cell function.
Interesting.
Oh, wow.
That's
interesting. You speak about, you actually speak out, about obesity on TikTok and advocate for those who suffer from the disease. Why are you such an advocate?
I am because, well, it's my job.
Right.
Patients come to me every day, but regardless of what I'm seeing them for, and so many of them struggle with weight loss, and I see how important it is to them, and I hear from them how frustrated they are, and it's taken such a long time for the medical community to understand that this is a chronic disorder. I mean, it got its own ICD-9 code over a decade ago. And even then, it was not recognized that it was a medical disorder. And not only that, but patients themselves have their own internal bias. They blame themselves. Dave, it bothered me every time you talked about normal weight and normal food and normal hunger. Because like, why is he calling it that?
because I never felt normal
to him. Yeah, because he feels abnormal.
Wow.
But that bothers me that you and I understand what you're saying.
Yeah.
But I think people they blame themselves, they blame their bodies, and that acts as an additional barrier to them seeking help. Because when you think it's your fault, you're not going to ask somebody else to help you, because you have to do that for yourself.
Yeah, that's so true.
And
We
hear
talk
people
about that.
talking about, they talk about cheating on their diet. It's not your spouse. You're not cheating on your husband. You can't cheat on your diet, because that gives it so much. It gives it a moral aspect to it.
Yes.
And
I'm glad that you said that.
It's not immoral. There's no such thing as a bad food. Otherwise, it wouldn't be food, right? It would be poison, right? There's some nutritional value to every food, some more than others, right? And some things you need to minimize, but even if something is all carbs and sugar, we need a certain amount of sugar in our body. So I tell them there's nothing bad, and saying that you cheated on your diet, like I said, just gives it a moral aspect I don't think should be there. So I advocate for people, because I see the struggle, and we can't help people unless they accept the help, and we can't help people unless we are willing to help. And opening people's eyes to that, I think, is the only way to get the treatment started.
We're trying to change within our community, and we're just trying to be loud, honestly. So, even this podcast is really about taking back our testimonials, but we know that there's a ton of obesity bias, ignorance, and hate. We all kind of encounter it daily. So you have spoken about this a lot in your TikToks, as of we. So we'd love to hear your perspective on that subject.
So, like you said, there's a lot of bias, and people are treated differently at work, in social situations, and even in healthcare settings, because of their weight. it's looked at as a personal shortcoming. It's looked at as a matter of lack of willpower, and it is very difficult for it's been and to be honest, for a long time that's what we all knew, right? We thought that was correct, right?
Yes.
And it is only recently being, the idea is being propagated more that that's not what it is. That, like I said, it is a chronic medical illness which has basis and it's very complex, has basis in genetics. It can be affected by other medical conditions. And then again, once somebody has overweight or obesity, there are so many changes that have occurred in the body that keeps someone from managing it with just, as you said, calories in, calories out. But people still see it as, calories in, calories out. And people say, well, why do you need medication? Why can't you just exercise? You eat less, do more, as they say.
Yep.
But as I said earlier, that is ineffective. People can do it for a little while, but it is not sustainable. I mean, the study after study shows that people who are successful at losing weight very often find that that's temporary, and they regain the weight and often additional to that. And until we recognize it as a chronic medical illness, people won't be able to get the care that they need.
Food has definitely been a very dominant voice in my head. That's not the main focus anymore. Dieting, exercising, and adding GLP-1s through Row is a game changer. I have such a sense of mental freedom since I started with Row. Food no longer controls my thoughts. Family time used to revolve around food, and now it revolves around what we're gonna go do together.